Affective disorders. Introduction. In this study session, we shall examine some mental disorders that are commonly referred to as mood disorders. These are explained with a case study. Furthermore, we shall make a distinction between primary and secondary depressions, as well as reactive or exogenous and endogenous depression. Furthermore, we will examine mania and also discuss organic psychosis. At the end of this study session, you should be able to 1. Highlight the general features of depression. 2. Differentiate between primary depression and secondary depression, as well as between reactive or exogenous and endogenous depression. 3. Highlight a case of mania. 4. Explain schizoaffective disorder. And 5. Point out the causes of organic psychosis. The meaning of affective disorders. Affective processes are commonly referred to as feelings, moods, emotions, and temperaments. Therefore, affective disorders are referred to as the disorders of mood and subjective feelings. Two major types of this disorder are depression and hypomania or mania. They represent two extreme continuums of the disorders of mood and affect. On one extreme is depression, which is a morbid state of low moods and sadness, and the other extreme is mania, which is a state of excitement and high elation. These disorders can be presented and manifested in the same individual at different stages of his or her illness. And when this occurs, we have what is called bipolar affective disorder, that is, a state of depression and hypomania. We can also have a state where just one continuum of the illness will be present as an illness, that is, a state of recurrent depression or a state of recurrent mania. When this occurs, it is known as unipolar affective disorder. Types of affective disorders. Depression. Depression has general psychological and physical symptoms. Among the general symptoms are low moods, sadness, or discouragement. The psychological symptoms include lack of enjoyment, diminished concentration or indecisiveness, pessimistic thinking, guilt or self-blame, negative self-reproach or self-concept, and reduced libido. The physical symptoms include reduced energy, constipation, memory impairment, psychomotor, agitation or retardation, loss of appetite, loss of weight or weight gain, and in rare extreme cases, suicide. The mood of a depressed person does not improve substantially in circumstances where ordinary feelings of sadness will be alleviated. Depression has three major components. These are pessimistic thoughts, lack of enjoyment, and psychomotor retardation. Pessimistic thoughts are a state of depressive cognition and can be divided into three parts. The first part is concerned with the patient's present circumstance. A typical patient sees the unhappy side of every event. He thinks he is failing in everything that he does and that other people see him as a failure. The second group of thoughts is concerned with the future. The patient expects the worst. He foresees failure in his work, finances, misfortune in his family, and consistent deterioration in his health. This idea of hopelessness is often accompanied by the thought that life is no longer worth living and that death would come as a welcome release. These gloomy preoccupations may prepare the mind of a depressed person for suicide. The third group of thoughts is concerned with the past. The depressed often take the form of unreasonable guilt and self-blame about minor matters. For example, a patient may feel guilty about the past trivial acts of dishonesty. The case below illustrates how guilt could manifest as part of a major depressive disorder. Miss L.A. is a 24-year-old female unemployed graduate. Illness started about 18 months before presentation when she was doing her youth service in Calabar, Cross River State of Nigeria. The problem started in Calabar as a result of a series of rituals that was being performed in the town at that time. According to the patient, a chief in the area was said to have died, and there was a stay indoors instruction. Symptoms included nightmares, insomnia, fears, that is free-floating, and occasional headache. On further interview, it was revealed that Miss L.A. harbored a serious thought of unfaithfulness. She was said to have slept with a man that was not her boyfriend. This morbid feeling of guilt, together with other physical anxiety characteristics, made her seek for the help of a psychologist. Another major part of depression is lack of interest and enjoyment. A typical depressed patient will show no enthusiasm for activities or hobbies that he will normally enjoy. He has no energy for living and for pleasure in everyday things. He often withdraws from social encounter and also has reduced energy. The last major feature is psychomotor retardation. The patients that are psychomotor retarded are often very slow in action. This slowness is reflected in their speech, and there is a long delay before questions are answered, and a pause in conversation. Their speech may be too long and intolerable for a non-depressed person. A distinction has also been made between primary and secondary depressions, as well as between reactive or exogenous and endogenous depression. A distinction has also been made between primary and secondary depressions, as well as between reactive or exogenous and endogenous depression. Primary and secondary depression. Primary depressions are depressive features that are not preceded by any psychological depression. On the other hand, secondary depression applies to all cases with a history of previous non-affective psychiatric illness, such as schizophrenia, of anxiety, neurosis, or of alcoholism, medical illness, or the taking of certain drugs, such as steroids. Reactive and endogenous depression. A reactive or endogenous depression occurs in response to psychological, social, or physical environmental hassles that normally accompany the day-to-day living or activities of man. Incidents such as loss of a loved family member or friend, loss of a job, being in debt, and failure in examination are parts of the factors that can predispose any individual to developing a reactive depression. It is often a milder form of depression, though it could be severe depending on the intensity of the precipitating factor or factors or susceptibility of the person to mental disorders. Endogenous depressions are those features without any apparent and major precipitating environmental factors. This is usually a psychotic form of depression, which the features have already been highlighted. When there is a condition of extreme elation, excitement, socially disinhibitive behavior, and violence, you are most likely to have a case of mania. Other symptoms of mania include irritability, pressure of speech, flight of ideas, increased libido, excessive spending, grandiosity, excessive eating, and unusually full of energy. Schizoaffective disorders. Schizoid affective disorders occur when symptoms of schizophrenia, such as hallucination, delusions of different types and disorders, such as the ones discussed above, manifest in a person. Organic psychosis. These are disorders that result from brain impairment and that have a known physical basis. Organic psychosis may be triggered off by infections such as syphilis, traumas such as skull fractures and concussions, nutritional deficiencies such as pellagra, cerebrovascular disease such as arteriosclerosis and brain hemorrhage, tumors, degenerative diseases such as Huntington's chorea, toxins such as lead, and endocrine dysfunctions. Basic and general symptoms of organic psychosis will include the following. 1. Impaired orientation. 2. Memory loss, especially retrogressive amnesia, that is, loss of memory preceding an accident or illness. 3. Intellectual deterioration, such as difficulty in planning, reasoning, and communication. 4. Blunted or exceedingly unstable emotional responses. The case study below provides a practical example of a person suffering from organic psychosis. Sheung, a 32-year-old laborer, was struck by a case following an evening of heavy drinking. He was brought to the emergency ward for assessment and possible management. On investigation, it was found that Sheung had a fracture on the left femur, multiple abrasions and contusions, and alcohol intoxication. He was placed in traction, sedated. On the third night of admission, Sheung woke up, disturbing other patients with screams and struggling. He saw and felt snakes crawling all over him. Because of the traction apparatus, he was immobilized, and this increased his terror. He pleaded with the nurse to save him. He was perspiring profusely, had gross and fine tremors. He was heavily sedated, and in the morning, he remembered nothing. Similar episodes, although less, occurred the next 2 nights. Forms of organic mental disorders. Acute brain syndrome. Acute brain syndrome is an organic state which is characterized by confessional states and delirium. The symptoms of confessional states include a transient awareness or clouding of consciousness. Memory impairment is common and the patient's mood is usually anxious. Insomnia and inability to concentrate are frequent complaints. Patients with this type of illness are usually referred to a general hospital as a complication to some physical illness. Chronic brain syndrome. This syndrome, which may also be termed organic dementia, is characterized by multiple deficits in intellectual function, performance, and personality resulting from brain damage. Delirium tremens. This is a special form of acute brain syndrome occurring in chronic alcoholics, especially when alcohol is withdrawn, but sometimes occurring during a period of unusually excessive drinking. The symptoms of delirium tremens usually come at night, with perhaps 1 or 2 days of preceding progressive uneasiness and apprehension. Generally, the patient experiences frightening illusions or hallucinations of a visual or tactile variety. These are sometimes intensified by related delusion. The patient experiences panic and tremor. He is disoriented, restless, agitated, and sleepless. The symptoms often subside during daytime. Physical illness associated with organic psychosis will include psychosis after head injuries and psychosis associated with nutritional deficiencies. Causes of organic mental disorders. Psychosis after head injuries. With the growth of industrialization and the increase of highway traffic in Nigeria, organic mental disorders that result from head injuries are becoming more common. Specific symptoms are determined by the extent and the location of the injury, as well as premorbid personality of the individual. Conditions resulting in psychosis from head injuries include 1. Concussion. This is characterized by a short period of unconsciousness following a hard blow to the head. 2. Contusions and lacerations. This is characterized by the crushing or tearing of brain tissues. It usually results from a heavy blow to the head, with or without skull fracture. Coma may result, and the longer the coma, the greater is the likelihood that brain damage has occurred. 3. Subdural and epidural hematoma. This results from a bleeding head trauma. Psychosis associated with nutritional deficiencies. Deficiencies in some vital vitamins in the body, such as vitamin B, can cause symptoms of anxiety and depression, followed by acute delirium, and sometimes with hallucinations and symptoms suggestive of schizophrenia. Thiamine deficiency can often result in irritability, anorexia, and insomnia. In its severe form, delirium can occur with amnesia, confusion, and other acute symptoms as noted under delirium tremens. Another nutritional deficiency is kwashiorkor. This is a clinical condition caused by deficiency in protein calorie essential for the body and is more frequent in young children. Abnormal behavior associated with this calorie deficiency includes depression, apathy, and a possible mental subnormality. Korsakoff psychosis is another condition associated with thiamine deficiency resulting from taking too much of alcohol. It is a cognitive malfunctioning condition. This condition is usually irreversible, and its essential symptom includes memory impairment, especially those concerned with registration of information. This memory defect, which may also be associated with diffuse hemorrhagic lesions in the brain, which may prevent new materials from being added to the memory storehouse, thereby contributory to the loss of vital information on the materials, making memory for events occurring a few minutes before the incident deficient. Senile dementia. Another organic condition associated with psychosis is senile dementia. This is a mental condition produced by regression in many physical and mental aspects of individuals who are usually above the age of 70 years. Prominent symptoms of senile dementia include memory loss, lack of or reduced interest, and preoccupations with experiences of long period of time, increasing self-interest and lack of self-control. Delusions, especially persecutory delusions and hallucinations, are part of the symptoms of senile dementia. Presenile dementia. Presenile dementias are neurological conditions which include Alzheimer's disease and Pick's disease. Alzheimer's disease is a neurological condition which occurs in an individual before the age of 65 years. It is characterized by a degenerative, slow outset of mental functioning. It has, in addition, a progressive deteriorating course. Symptoms include agitation, emotional outbursts, disrupted sleep, and amnesia. Pick's disease, on the other hand, is less common. It reaches its peak in the 50 to 70 years old age group. It is distinguished from Alzheimer's disease for its disinhibited, tactless, and facetious personality deterioration. The language tends to exhibit stereotyped output, and they often exhibit echolalia and autism. Tumors. Brain tumors and tumors of the menines can cause general symptoms similar to those resulting from other lesions. Abnormal behavior associated with brain tumors include speech disturbances and various personality changes and psychotic features found in chronic brain syndrome. Psychosis resulting from progressive neurological illness. Common under this classification above is multiple sclerosis. Outstanding feature of this progressive neurological condition is euphoria. Depression is also common, and eventually there is a progressive intellectual impairment. Huntington's chorea is another progressive neurological condition. It is transmitted by a dormant gene. The outset is usually between 30 to 40 years of age. Symptoms include incessant jerking, twisting movements of the neck, tunic and extremities, as well as facial grimacing, explosive speech, and ataxia. Psychosis associated with severe medical illness. Some chronic and severe medical conditions, such as heart, liver, and kidney diseases, or even cancer, can predispose an individual to quite a number of abnormal behaviors. Common psychological distresses associated with these conditions include confusion, anxiety, agitation, delirium, and panic attack. These distresses may be caused both by anxiety arising from the knowledge of the life-threatening nature of the illness and from physical influences on the cerebral cortex, which include lowered oxygen content and unexcreted toxic substances circulating in the blood. Confusion is frequently associated with hypoglycemia in patients with diabetes. Study session summary. In this study session, we have examined mental disorders, which are commonly described as mood disorders. Furthermore, we made a distinction between primary depression and secondary depression, as well as between reactive and endogenous depression. We also examined other forms of mental disorders, such as mania, schizoaffective disorders, and organic psychosis. Lastly, we highlighted causes of organic mental disorders. Specifically, we mentioned and explained the psychosis that result from head injuries, those that result from nutritional deficiencies, senile dementia, presenile dementia, tumor psychosis that results from progressive neurological illness, and that which results from severe medical illness. End of study session 6. Thanks for listening.